It's my pleasure to introduce Lee Benson, who's my mentor and who trained me and is, in my opinion, one of the finest interventionalists in the world, to talk to you about getting to your 10,000 hours.
Thank you very much. And I want to echo Eric's welcoming comments to the meeting. I hope that you enjoy your day and a half with us in Toronto. So I was giving some sort of to talk about some of my thoughts on building a successful career, perhaps based on some of my experiences. And really, do you really need 10,000 hours to get it right? Or you don't, you idiot, he says, cast the nets. Cast the nets. All right, I thought that was funny when I found it. Anyhow. So building a successful career, it can be challenging. And the question I ask is, are there behaviors or conceptual frameworks that we can use to become part of our own personal fabric to become successful? So where do we start? And I think everybody in this room has seen the famous 5 A's of medicine, of availability, affability, ability, and of course affordability and accountability. And they sort of are surrounded by procedural skills and risk management and building a practice. And of course, as Eric says, it's important to have a mentor. I think we've all had mentors in our careers. But basically, and I think that the summary of this entire talk is basically you've got to be a mensch. That's what it's all about. You have to be a mensch in every aspect of your career and your life. So these are just some thoughts that came to my mind as I was typing up this talk. You have to keep your patient's best interests at heart. You have to be very thoughtful, and if you wouldn't do it to your kid or your brother or your sister or your mother or your father, certainly don't do it to your patient or do it to your grandchild. This is my grandson. He's 8 months old, and I promised my daughter that I get her son into in one of my talks early on. And you have to think physiologically as well as anatomically as you approach patients with congenital lesions. Now, this is a patient that I cathed a couple weeks ago. For the pediatric cardiologist, you could see it's a Glenn. This was a pre-Fontan cath. We did an injection in the innominate vein, and oh my God, the azygos vein is lighting up. What is going on? What is actually the cause of this? And one has to then think about other anatomic problems. This patient has severe left pulmonary artery stenosis. He also had elevated PVR on the MRI catheterization. So you have to think both physiologically and anatomically. Now, this is a case that Phil Moore let me use. This is a case that he did in San Francisco some time ago. It was a patient with an atrial septal defect. He took the patient to the catheter laboratory, did a right heart study. Those are the saturations. SVC sat was 79, atrial sat 83. IVC sat was 63, but he didn't pay much attention to it. He went ahead and closed the atrial defect, and lo and behold, he missed an innominous vein. So one has to look at your data as you're acquiring it in the laboratory and be thoughtful about the hemodynamics, the physiology as you're moving along. I think it's pretty easy as an interventional cardiologist to say, well, it can't be done or I shouldn't do it. And I think there's something that we should always put in our back of the minds. And this is not to be cowboys, mind you, but the surgical alternatives have their own risks as well. And transferring our risk profile to the surgeons does not necessarily guarantee risk reduction. It's actually risk aversion on our part. This was a patient who had bilateral arterial ducts. By the way, it's ducts, not ducti, in case anybody's interested in the Latin. Surgeons wanted to do an operation. We said no, we stent these. The patient went home, although the vascular access for this was from the left carotid. And you should always remember that the therapy cannot be worse than the disease itself. So here's a couple of cases that I came about in the last few years I thought might be interesting to think about what you're doing as you proceed through the patient management. This girl is now 12 years old. She had pulmonary atresia VSD and has a TIA.
3 days of age, we tried to
audio?
perforate the outflow tract, but succeeded in only perforating the wall of
I'll go back because this is so I don't have to talk
At
so
3
much.
days of age, we tried to perforate the outflow tract, but succeeded in only perforating the wall of the
Of the right ventricle. So that's what happened. We took her to the lab, didn't work out so well. So at 8 days, she had an operation. The surgeons did a RVPA conduit, left a small ASD. At a year, she had conduit stenosis. We had to take her to the laboratory, put stents in the conduit. I couldn't show you the videos because the Kodaks were wrong. But over the years, she had done very well. Mild RV hypertension, 2/3 systemic, not too bad. Saturation 93, but I knew she had a little ASD. She desaturated a little bit during exercise, didn't have an elevated hemoglobin. And then she presented with a TIA. Right arm and hand numbness, slurred speech, no headache, normal EEG, normal brain MRI, carotid Doppler, Holter thrombophilia workup was negative. I did a bubble study, very positive. Pretty cool, I know what's going on.
Now I am feeling pretty smart. She must have an atrial level shunt resulting in a right to left shunt and the TI.
And a TIA. I don't know why it's not coming out. So we take her to the laboratory, and I zap in a PFO device to close her defect. Unfortunately, or maybe fortunately, I decided to do a bubble study after I released the device, and it's still positive. Something's not right here, right? So I do
I feel really stupid, especially in front of my
in front of my fellows. You don't want to feel stupid in front of your fellows. I mean, your fellows are supposed to be feel stupid, but not you. So here we close the PFO, and you see I got a right to left shunt. So I do a right atriogram, and I see something that I should have seen before, and just look right over here. So what's going on there, guys? Okay, I didn't know what it was either. Yeah, you guys are really smart. Okay, there you go. But you already knew the answer. Unroofed coronary sinus. We balloon occluded it. Pressure went up to 35. I said, okay, I'm done. Went to surgery, had the conduit replaced, and had that tunnel to her, had that fixed.
I
All
hope
right.
you do not make this mistake. You can avoid it by thinking about the anatomy before the case and do not jump to conclusions that seem obvious. I hope you enjoy the rest of the meeting.
Yeah, well, just remember in the cath lab, as in forest fires, big problems always start small. So this is another case that I thought was going to be a slam dunk, going to turn out to be quite a nightmare. 3-day-old baby, double outlet right ventricle, pulmonary atresia, duct-dependent pulmonary blood flow. This is a number of years ago, guys. So now that PDA stenting is, sort of the thing that we do. The surgeon said, well, they'd rather have the kid a bit older, primary repair. Can I stent it? Of course we can stent it, not a problem. So we take the kid to the lab, the anatomy looks pretty good, SAT's around 75%. Decide to go retrograde, that's the procedure we use, and I put the catheter in there, uh-oh, the duct is closing. I take another picture, SATs are 45, anesthesia is yelling at me. This is what they look like in my eyes. I'm getting very annoyed. What should I do now? I'm not very happy. I call the surgeon, get the surgeon in here. It's a nightmare. He puts the kid on ECMO. I love the surgeon now. Everybody's happy. Things are stable. I have a pathway to the duct. Even anesthesia is happy, which is an adventure. So we go in and we stent the duct. We think things are pretty good. It's not playing, but where everybody's happy. The stent is in the duct. I actually had to put 2 stents here. You can't see them very well, but there's 2 stents in there. And we're sort of jumping up and down, hey, hey, hey. And then I have to take that wire out. And the wire, as you notice, is curved. And when I pull the wire out, it snaps onto the end of the stent. And so it looks pretty good. I'm pretty happy there. And then what happens is that what happens, all right? Not good. I'm not happy. You always have to have a plan B and be prepared, like the Boy Scouts and the Girl Scouts. Always be prepared for something that may not go the way you think it may go in your mind's eye. So just a few more minutes. what other tips can an interventionist use in order to be successful? Well, there's tips for good behavior. This is very typical in the cath lab at TGH with Eric and some of his fellows. Obviously didn't do a good job there. Tips for teamwork. You have the tips for working on imaging, tips for technique. Take advantage of the experience of other people, which is what this meeting is all about, actually, is the advantage of people who have done this before. You have to learn from the mistakes of others, because you're not going to live long enough to make them all yourself. So it's very important to take advantage of this kind of a meeting. Avoid traps and procedures. If you know that there's going to be a problem, try to avoid it. For the adult cardiologists, femoral artery access is a big deal. Not such a big deal in kids. Very normal vessels. We've always perked too low. Eric keeps telling me. But if you perk too high and you're an adult, you're in trouble. Big problem, even before the procedure starts. So it's much easier to stay out of trouble than to get out of trouble. Always remember that. It's sort of our theme. On the 25th of June in 1876, George Custer, he received some information. There were some Indians gathering at the Little Bighorn. He didn't analyze what was going on. He decided to ride out and surround them with 250 soldiers, but there were 3,000 Indians, and this was a mistake. So he wasn't thinking about what was going on in the procedure. Just some closing comments. I think it's important to respect the people you work with. It's very interesting how hallway conversations can get out of control. You've got to work together. You have to provide a very great service. You have to be, again, available, affable, and able. So what about available? Well, don't be MIA. Don't be slow in responding to questions from your colleagues when you are asked for advice. And I have to say, sometimes you have to hold your nose and just say yes to somebody who wants a procedure or wants an opinion that, well, I think you're an idiot, but, we'll do it anyhow kind of thing. You have to get to know your referring doctors, maybe not as close as these two, but you have to know them. You have to be friendly. You have to call them with results, and you have to let the doctors know what the plan is so that your referring doctors know what the plan is, so you can get on with the patient's care, and don't criticize their plan. Maybe you can help them adjust it. And build bridges. This is a team sport. It's not just us in the laboratory. It's the nurses. It's the radiology techs. It's the hematologists. It's the ACHD doctors, et cetera, et cetera. It's all these participants that work as a team to take care of our patients. So in closing, don't overestimate your skills. Early in your career, be overcautious. In my parting words to my fellows, I always say to them, do a pulmonary valve dilation. Maybe you shouldn't do a stent and a conduit as your first case. Ask experienced partners to help on tough cases. Ask someone to help you scrub in, even if you don't think you need it. It's good for community activity. Meet the families before cases. Don't do a case without speaking to the families or to the patients. They have to see your eyes. Don't just walk into the laboratory, because if something goes wrong, the first time you see the families is not to tell them something went adversely. And don't do this kind of guy. Always ask questions. If you don't ask questions in the laboratory, I'm not sure you're there. So asking questions is very important, and don't focus on the child or the adult patient, or focus on them and not just the procedure. And remember, you only have one chance to build a reputation. This is a sort of a statement people have said over and over again. It takes 1,000 cases to build a good reputation, and only one case to ruin it. And I stole this from Erica. I've heard it said the difference between good and great is courage, but you've got to know the difference between courage and stupidity. So keep calm, practice those 10,000 hours, and in closing, just remember, it's not just grammar, the difference between knowing your shit and knowing your shit. Got it? Yeah, you don't have to think about that. Okay, good. Thanks very much.